Something I've been doing for 5 decades at this point is summarizing the literature on what works in treating alcohol problems. And so that's what I want to offer you in this short segment that we have. What do we know about what works in treating alcohol problems, alcohol dependence? And this project we came to call Mesa Grande, but it is a review of the evidence of what works. Started in 1979, and we kept updating it and continuing until 2003, and then I retired. And no one has updated it since, and I know why, because it's an awful lot of work. It's a huge project. But we looked at all controlled trials that were comparing an alcohol treatment with an alternative condition, either a control or some other treatment. Every study was given a quality score, so how good is the study? And every study was given an outcome logic score. Does it say that the treatment works really well, or works fairly well, or doesn't seem to work well, or has really terrible outcomes? And putting those together, we were able to calculate what we call the cumulative evidence score for each treatment, just by adding all of the studies together, weighted for how good the study was. Our final version, which is what I'll summarize for you, had 381 controlled trials in it. This is just alcohol problems now, with 99 different treatment modalities being studied and over 75,000 patients included in these studies. So it's a large body of literature. And the question is, what works? These are cumulative evidence scores, and so the bigger the score, the more evidence there is that this particular treatment is working well for alcohol problems. And to our surprise, what had the most evidence was what I had talked about earlier, which is brief interventions, doing something relatively short to try to encourage the person to change their drinking. And we removed all of the studies that were motivational interviewing, and even so, brief interventions had a very good track record. So it's worth doing something brief. Certainly much better than a waiting list, certainly much better than doing nothing. The most supported treatment beyond those is the community reinforcement approach, which many people have never heard of. The essence of it is helping people to develop a life that is so good you would not want to give it up by drinking. So it's based on positive reinforcement. Then self-help manuals, you've seen some of the data on that, the reasonable background there. Self-control training, helping people to learn either abstinence or moderation. Contingency management, directly reinforcing people for staying sober. Teaching coping skills, getting down to the smaller effects. And relationship therapy, behavioral relationship therapy. At the other end of the scale, we have things that really didn't work. And most spectacular of those was alcoholism education. So showing people films, giving them lectures about alcohol and what it does to the body and the disease of alcoholism and so forth, basically has no impact. Alcoholism doesn't seem to be a knowledge deficit, You're not going to educate it away. General counseling that's not really well defined, no impact. Insight psychotherapy, nope. Confrontive therapies, every trial is negative. We thought relaxation training might be helpful, but turns out that it wasn't. This is another form of confrontation. Milieu therapy and forcing people to go to Alcoholics Anonymous, all of them on the negative side of the scale. So it doesn't matter what you do, and there are a lot of differences in outcome depending on what kind of treatment is being provided. Now, we just updated our book, Treating Addiction. It just came out last week. And so I was thinking, what would we add to that list from 2003? And I think there's now very good evidence for a form of therapy that helps people to get involved in the 12-step programs. That's not to be confused with sending people to Alcoholics Anonymous, but it's usually a 12-session therapy to help people understand the 12-step approach, help them begin to get engaged with it and start going to meetings. And we would also add mindfulness meditation now, contemplative meditation. Nice literature in addictions more generally and specifically with alcohol. There's even better support for the community reinforcement approach and something new called CRAFT, which is working with family members whose loved one refuses to get help. So we would get these telephone calls at our treatment centers saying, my husband is drinking so much and he refuses to get help, what can I do? Or my son is using drugs and he's stealing from us, but we don't want to put him out on the street, what can I do? And the people answering the telephone didn't know what to do, didn't know what to tell them. So we developed a method that I'll tell you a bit more about later on, based on the community reinforcement approach, to bring in the family without the drinker or without the drug user and work through them to begin to change the alcohol and drug problem. Contingency management has still stronger support, and now a medication, naltrexone, has a small but consistent positive effect by blocking opiate receptors, which are part of the reinforcing nature of alcohol. So here are some themes that I would abstract from what we've learned. Certainly, brief intervention can make a difference. People don't have to go to a specialist addiction treatment program. This can be done in healthcare, it can be done in social services, it can be done anywhere you meet people who are likely to have alcohol drug problems. And they're much more likely to go for healthcare, much more likely to go for social services than they are to turn up at an addiction treatment program. So you don't have to wait for people to go into a specialist treatment program. There's something you can do to make a difference. We certainly encourage healthcare programs to screen for alcohol use, and when someone is using more than a recommended amount of alcohol, to do something to help them cut that down. And the message I've already told you, which is don't have waiting lists. I don't know if you do here, but it's very common in the States for people to call for treatment and say, well, we have a waiting list, so we can see you in 3 months. Well, that's not good enough. No. Second, covered earlier, be empathic rather than confrontational. Giving hard-nosed advice, being authoritarian, trying to crush people's denial, confronting them with reality, none of those things work very well. And therapists have a very large effect on outcomes. So who is treating the person matters a lot. As you saw, there can be therapists who almost all of their clients benefit, and others, very few of their clients benefit. And I think we ought to be tracking the outcomes of clients by therapists just so we're aware of this. It matters what you do, and it matters how you do it. And accurate empathy, the skill that I've talked about, is a learnable skill. And I just 2 years ago wrote this book called Listening Well, which is basically for everyday people, what is empathic listening? You want to enhance the client's own motivation for change, and you can build motivational interviewing into treatment programs, and it improves the efficacy of treatment. Contingency management, this was very controversial when it began in the States. Like people come in, and if they have a breath test and there's no alcohol, they get a prize, maybe a little cash prize. They began to going to a lottery drawing, so you get a little slip that may be worth a lot of money or a little bit of money, or may just say good try and try again. It tends to work. People are more likely to stay sober, more likely to stay drug-free if when they come in, positive things happen. So therapists often didn't like that. We shouldn't be paying clients for doing what they should do anyhow, but if you want them to get better, actually it can help. And then I've mentioned craft of working with the family. This is Bob Meyer's book For the Family, on how to help your loved one get sober. Alternatives to nagging, pleading, threatening, advising, all of those things. Well tested, and even the book itself, we found, can really help families. Not as many as working with a therapist, but maybe 1 out of 3 families can benefit just from working with the book. There's also a fourth emphasis is help people make their sober life better than their drinking life. In other words, they should be having a good life that doesn't involve alcohol. Just getting people to quit drinking doesn't solve that. You're just taking away a major source of reinforcement, but not replacing it with anything else. And in the community reinforcement approach, there are therapist manuals for how to learn that. Strength and coping skills. You heard a bit about this earlier. And one in particular is teaching people skills for how to deal with craving, so they don't immediately drink or use the drug just because they're feeling craving. One important thing to know is craving is temporary. Ellen Marlatt talked about urge surfing. That is when you feel an urge, just ride it out and it'll pass, and just don't respond to it immediately. So those are good skills to teach. Mood management, again, for the reasons that you heard earlier, that people often are using alcohol to try to manage their moods. You can teach them cognitive behavioral methods for managing their moods so they don't have to rely on alcohol. And improving relationships really makes a difference. If you're treating people with alcohol problems, it's generally a good idea to bring the spouse in as well and work with them together. It's not as easy as just seeing one person at a time, but it's more effective. The spouse knows a lot about what's going on, can actually help with the recovery process. So we encourage treating couples together. And then self-help materials, as I have mentioned. Have clear goals and plans for reaching them. This may seem kind of obvious, but what is it that we're trying to accomplish? And it's not a goal until the client shares the goal. Now, you may have goals the client doesn't share. I want my client to stop all drugs and alcohol and never ever use again. But what's the client willing to do? What would be a first step? In the community reinforcement approach, we use something called sobriety sampling. Well, would you be willing to try, say, a week without alcohol and just kind of see what it's like? I'll check back with you in a week and we'll kind of see what's going on. And people are often quite surprised. Now, if they're going to have withdrawal, they experience it during that time, but most people with alcohol problems are not that physically dependent on it. That's also to say, don't just wander together in the wilderness. Don't just sit and chat and talk about whatever. I mean, know where you're trying to go and have a plan for getting there. Pay attention to social support systems. We tend to sit with one person at a time in our therapy room and ignore the fact that they have all these friends and relationships and family and so forth. And who are those people and what's their influence on the drinking? If they're surrounded by, if all their friends are people who drink heavily, if you get them to abstain, you've created a problem for them because it's very hard for them to stay with those friends now. So what do you do? Include significant others in treatment when they can be supportive. One thing we found in that big Project Match study was that when people's social support systems mostly support drinking, as all the people around them favor drinking too much, they particularly benefit from 12 steps from Alcoholics Anonymous, because there you have an immediate support group to encourage you to abstain. And I've mentioned community reinforcement, which also is looking very much at who's encouraging drinking, who's supporting your sobriety, how do we relate to those people with treatment. Here is our first study with Kraft. So this was in response to the people answering our phones saying, what do we do? And it's a randomized trial in which we randomly assigned family members. Now, the drinker or the drug user won't come in. They're refusing to come in. So randomly assign family members to go to Al-Anon, and actually give them a form of therapy to encourage them to get involved with Al-Anon and understand it. Do you have Al-Anon here? Is that familiar? A little bit, yeah. Or the intervention, which is sort of like a surprise party where you bring the person in and everybody tells them what's wrong with their drinking, and usually there's a car with the motor running outside the door, and you want to whisk them off to the hospital. That was very popular in the States. Or craft, and we randomly assigned people to those 3 interventions. They got up to 12 sessions of whatever kind of family therapy it was. And in craft, we instead of saying what Al-Anon says, which is you're powerless and there's nothing you can do about this, what you need to do is detach from the person and stop trying to control them. It's a different message here, which is as a loved one of this person, you actually have a great deal of influence. And the important thing is to be using it in the right way, and particularly using positive reinforcement in the right way. So it's teaching people how to use their influence to change the behavior of their loved one, working on improving the quality of family life, and then waiting for the moment when the person is ready, and then they call the treatment center and they get in right away, which is important. So how many people got into treatment? In the Al-Anon approach, 13% got their loved one into treatment. In the intervention approach, 22% got their loved one into treatment. In craft, 64% got their loved one into treatment. Now, in all 3 conditions, the family benefited. So the family members were less depressed, they were healthier physically, they were feeling better about things. The big difference was in whether their loved one got into treatment or not, and it was a huge difference. That's now been replicated in 6 different countries, with an average of 2/3 of people getting into treatment within a couple of months, really. So there is a way to work with family members to get their loved one into treatment, even when the person initially refuses to come. Theme number 8, pay attention to what else is wrong, because alcohol problems or drug problems rarely happen alone. People with alcohol drug problems usually have other medical problems. They usually have other psychological problems. They have social and financial problems. And helping them to address those actually helps them stay sober. We used to think all you need to do is get them to sober up and everything else will take care of itself. Not true. It doesn't automatically fix other things. And if you help to improve the relationship, if you help them to figure out how to deal with their financial crisis, if you help them figure out how to deal with their moods and so forth, you really increase the chances of sobriety. Now, what about treating alcohol problems in the healthcare and social service system? So these are places where people are coming for medical care, or they're coming for welfare support, or they're coming to look for a job, or they're just coming for other reasons that aren't directly related to drinking. And yet, there are lots of people there who have drinking problems. And part of the reason that they're there is they're drinking, you know. Often it just gets ignored and not treated, but you can do something right there. In healthcare, for example, there are way more people with alcohol use disorders than there are in the general population. They just tend to be sicker, and so they come in with all kinds of medical complaints. And if you're a physician and you're treating somebody who's a drinker, it's going to impact everything else that you're trying to affect. If you're trying to get their mood managed or trying to deal with their gastrointestinal problems or whatever, drinking is kind of getting in the way of getting that stabilized. You can find people much earlier in healthcare and in social services than you will in addiction treatment programs. There's just less stigma involved in that. Brief interventions can work. There also are some pharmacotherapies that can help now. And in a way, what you're doing is preventing the development of severe problems if you can find people earlier and help them turn their drinking around before it gets too serious. There are 3 models for doing this. One of them is refer people out for specialist care. That's what usually is done. So the doctor sees an alcohol problem, said, well, I want to send you to the alcohol treatment program. Less than 10% will get there. You know? The stigma is so great that people simply don't go. I mean, they just won't go even when their physician refers them. At least that's our experience in America. But that's been the most common thing. Second thing is to teach the primary care provider how to do brief interventions, how to do something relatively short that's likely to make a difference. But I think the best of these is to have in the healthcare setting a psychologist or a behavioral specialist who can help the person to deal with their problems. We began about 10 years ago placing a psychology graduate student in the family health clinics in Albuquerque. It took about 6 months for the physicians to get used to this person being there, and they weren't quite sure what this was about. But then they really liked it. And when they're talking to a client who's drinking, they can actually call this person into the room, or they can walk them down the hall and do what we call a warm handoff, you know? And not just about alcohol. If you're working with somebody that has diabetes, you can walk them down the hall to the behavioral specialist to help them make changes in their diet and in their exercise and in their self-care in lots of ways. So having somebody who knows how to do behavior in a healthcare clinic is a good idea, because often that's the thing doctors are not taught how to deal with. You can blame people for not changing, you know, but how do you help people change behavior? It's just usually not part of medical training, and yet it is the primary cause of chronic illnesses, and it is the primary thing that determines how healthy or ill people will be if they have a chronic condition and their survival. That apparently is the end of the things I have to say. So I may have raised quite a few questions along the way. I was trying to summarize for you a big body of evidence and do so in a reasonably short period of time, but I'm happy to take questions you may have.
So, me oleme siis valmis küsimusteks. Väga inspireeriv olnud kõigi nende meetodite ülevaade siin, et kindlasti on saalis peegeldusi selle kohta, nii et palun, julgesti. Maybe I kick off with a little bit awkward question, but have any of these methods been tried, for example, in a closed setting like a prison environment? Do you have any?
Well, certainly hospitals.
Hospitals, yes.
Prisons less so. The main thing that we're doing in prisons is medication, like methadone or buprenorphine. There are treatment programs for addiction in prisons, but I think the quality of them often is not very good in the United States.
Right.
But there's no reason why you couldn't. If someone is coming up on their release, for example, begin to teach them some coping skills so that when they get out, often common outcome is you get out and you start using that day again, you know, to work out a social support system to help them, to teach them some coping skills, maybe get them started on a medication that will help them before they're released. And we've not done a good job of that in the States. I would like to see much more of it.
The reasons I'm asking it is particularly, well, I think also elsewhere in the world, but in Europe there is the prison commitments are usually getting shorter and shorter, but,
yes.
But there's an opportunity, particularly if you have in mind that a large majority of people have actually substance problems who are imprisoned.
Yes.
This is a unique opportunity to get to them in a way, in a concise environment, and then particularly the pre-release, and then motivating them to move forward with a life who could make an opportunity.
Yes. Yeah. Motivational interviewing is being tested in those settings, so I think that's an exception to the rule. And especially probation and parole officers are applying motivational interviewing in the work that they do. So they're following the person either instead of incarceration or after incarceration.
no nii, aga veel küsimusi? Võtame mikrofoni.
I had a question about the craft approach.
Yes.
Would it be adaptable to different psychiatric diagnoses, like psychotic and, I don't know, depressive patients? And the book that was in the lecture, is it something you can study from,
Yes.
like the method?
Yes.
Thank you.
Now, it's a good idea to apply this with other psychiatric conditions. The only one where it's sort of been tried is with the post-traumatic stress disorder in combat veterans. So often they come back, very little is done to help them get back into society again. And they have PTSD, may not even realize it. The family knows. And if you can engage the family, I think you could use the same kinds of methods to help the person get help before they destroy the family, before all these terrible things happen. But it's essentially just teaching family members to use positive reinforcement instead of punishment, and to use extinction, that is, to not reinforce the wrong thing. Something that families sometimes do when they have a drinker in the family is they try to protect them. If they come home, fall asleep on the rug and vomit, the family cleans it up, they take them, they tuck them into bed, and they wake up in bed in the morning nice and comfortable, As long as their life is not in danger, we would say leave them on the floor, Let them wake up with the consequences of their drinking. So don't get in the way of consequences that are not life-threatening for the person. But even more important than that is when the person is not drinking, now you express appreciation. Now you do the special things for the person. And let them know, I love you so much when you're sober. It really makes a difference to the family. And look, the kids are very happy with how you are now. So it's something that can happen relatively quickly. It's getting into your head that you have influence in the form of reinforcement, that punishment is not going to be very effective. You cannot punish addiction away. It doesn't happen, or at least not very often. And so it's mostly that. And so in that regard, to the extent that the family can do things that are helpful in managing the psychiatric condition, you could use the same kind of approach. It just hasn't been done much to my knowledge so far, so it's a very good idea.
Thank you.
I have another,
Over here?
Oh, yeah. While you take the microphone, I have a question about dual diagnosis patients, for example. It's usually quite problematic, particularly in specialized care in psychiatry. What would be the approach when you have somebody who has both lines in the game, as we put it? So where would you prioritize the abuse or the substance abuse issue?
Sure.
Put it on the first place, or?
What I often say, tongue-in-cheek, is dual diagnosis is a good outcome. If you can get it down to 2 diagnoses, good. That's pretty good. But I think the research says treat them at the same time, treat them together, rather than treating the alcohol problem and then they go to the mental health center, or treating the mental health thing and then you deal with the substance use later. It makes sense to have integrated treatment. Now, I don't know what your providers are like here. In the States, we have a lot of people who are addiction counselors, and all they know is addiction. And they're not well trained in psychology or other kinds of fields, so they're really not prepared to treat other kinds of problems. And so that creates an obstacle. I think ideally, someone who's treating addiction is going to see the rest of the diagnostic manual. It all comes together. And having the skills that it takes to treat these things together, I think, is what clearly is the way to go. Sometimes you want to wait a little while, detox the person, see if they're still depressed, or does it go away when they stop drinking. But deal with it together, rather than thinking we need to do this one first and then that one next.
We will not treat your depression before you're sober.
Oh, this doesn't, and patients get put in this, we can't treat you here because you have a mental health problem, so go over there. well, we can't treat you here because you have an alcohol problem, so go over there. They give up. Yeah.
Mu küsimus oli osaliselt seotudki doktor Lehtmetsa küsimusega, ehk nendes uuringutes ja nendes tõendites, millest siin oli näiteid, et kui palju seal tegelikult oli, et valdavalt siis mõõdeti alkoholi tarvitamist, eks ju, ja alkoholi tarvitamisega seotud tulemusi, et kas seal oli ka variatiivsus kaasuvatest haigustest tulenevalt, ADHD ja nii edasi?
Sure, yeah. Well, a problem with alcohol research often is people are eliminated from the study if they have some other condition. We're doing that less and less, but many of the studies that I showed you would have been mostly alcohol problems. You can get in if you're kind of depressed also, or what, but if you have schizophrenia, you won't be getting into the study unless it's a study about schizophrenia and addiction together, and there are actually a fair number of such studies. So that's one thing. Almost always consumption is measured, either alcohol consumption or drug use. Almost always there's a double check for the honesty of the person, either through biological markers, which are not all that sensitive actually, or we just interview family members. But what we found over time is that actually the best report of use is the person's own report, that they know more about their drinking than anybody else does. And so in general, self-report is a pretty good measure here. But just because there's so much skepticism about self-report, we've almost always checked. But checking didn't change the picture for us, and didn't change the outcomes for us. So yes, you always measure consumption and use. Many studies also measure problems related to alcohol and drugs. Some also measure physical health in relation to it. But it's very common to measure alcohol problems as well. We developed scales for doing that.
Ja teine küsimus, et kas MI tulemuslikkus sõltub kaasuvast diagnoosist?
Surprisingly, no. There were all kinds of diagnoses where we thought it will not work here because, it will not work here because the person has schizophrenia. Really, is this going to have an impact? Well, it does, as it turns out. Have a nice impact on medication adherence and on rehospitalization. In the Project Match study, we thought people who are scoring high on the psychopath scale, on the sociopathic characteristics, well, they won't respond because those people don't form relationships. And this is a relationship-based therapy. Wrong. It was just unrelated to the person's score on that particular scale. Brain injury. What about people that have a serious head injury and they got lots of impulsivity problems? Probably won't work there. Actually, it does. There's nice literature now on closed head injury and motivational interviewing and helping people to manage their substance use and their impulsivity and so on. So what I usually say when someone says, well, can you use motivational interviewing with, fill in the blank, what I say is try it and see, because lots of diagnoses where we had a rational reason to think it wasn't going to work, it did. And I think this is so much about human nature, so much about relationships, that it just seems to have an impact on an amazing array of things. I have sometimes said that another way of asking that question is, where will love not reach? And I'm sure there are some places, but try it. We don't know about autism yet, for example. I suspect that kids generally need to get to be about 15, 16 before they themselves will respond to motivational interviewing, because part of what you're doing is triggering self-regulation. But if they're younger than 15, you should be talking to the parents anyhow, because the parents are the frontal lobes for these kids, you know. But other than that, we haven't found, I thought it was going to be smoking. The first 10 years of motivational interviewing research with smoking, there was like no hope. It was like zero response. So I thought nicotine addiction is just too tough. This is not going to touch it. And then it took off. And there are now so many positive studies that it is listed by the Cochrane Group, which does these healthcare analyses, as an evidence-based treatment for smoking cessation. So why the first 10 years wasn't it working? I don't know. And seems to work particularly well with disadvantaged and marginalized people, with people who are homeless, with people who have diagnoses that get them rejected from society, with people with HIV or you know, injection drug abuse. And interestingly, that's often the first place that motivational interviewing goes when it finds its way into a society. It's used with some of the most despised and rejected and outcast people, where loving is unbelievably powerful. You know? We have found that motivational living is more effective with minority groups in America, that is brown-skinned, black-skinned people, than it is with white people. Like 3 times as effective. Didn't expect that. What's that about? Well, if you're a person of privilege, you're used to being treated with privilege. You're used to being treated respectfully and kindly and so forth. If you're in one of these marginalized groups, you're not accustomed to people treating you with respect. And when it happens, it's very powerful. Yeah. My best guess. Yeah.
In Estonia, the overall picture concerning also alcohol use is changing, as it probably changes everywhere. But one of the topics over the last years has been the largest spread of marijuana, particularly among the youngsters. And maybe you could comment, perhaps, if you have a kind of a multi-users. Are there different approaches? Motivational interviewing or?
Well, in America, multi-use is the norm. I mean, we used to have alcohol treatment programs and then drug treatment programs over here, separate, you know. And the clients just began mixing it all together. And so if you want to do a study with people who only use alcohol, you have a hard time getting your study sample, you know. So that's actually the norm. Dual diagnosis is the norm. To have something else besides the substance use problem, that's just how it is. I mean, and literally we saw the whole diagnostic manual in an addiction treatment center. You know, all these things are overrepresented with alcohol problems and drug problems. So you just get used to kind of dealing with whatever combination the person brings, figure out where they're willing to start, you know. That's the kind of harm reduction idea. If they're not willing to quit everything right away, well, would you be willing to switch off from injection drugs to oral drugs, which are less dangerous, you know? Some therapists have a hard time doing that, but it can be life-saving, you know? So, and once you start and the person begins seeing positive changes based on these little steps, they'll take some more steps and some more steps. So it was a little like our finding with teaching moderate drinking to people who ultimately quit. They tried that as a first step, and then they said, well, but what's the point in drinking moderately? I drank to get drunk, so I might as well just quit. And I would say, well, okay.
Yeah, sorry. Exactly. Yes.
Tere! Tahtsin küsida, et aga kui inimest toetavad perekond, sõbrad ja ta ikkagi ei võta nagu seda motivatsiooni noh, ta ei võta tõsiselt ja ta ütleb, aga talle meeldib juua. Et mida siis teha ja veel üks küsimus, et kuidas te suhtute kodeerimisse?
On codeine? On
No,
Kodeerimisel.
I should translate.
coding?
Coding. It's
Tell me what it
Alkoholi
means.
kodeerimist.
well, if I knew, I would tell you. But
Oh.
I suppose
What-
it's
tell me
a
what
kind
coding-
of intervention where you psychologically influence people by coding their brain.
Oh, don't know anything about
In a
it.
way to stop them drinking. It's been quite
Yeah.
popular in certain countries,
Oh, really? Okay.
also from time to time here. So I would call it a psychological intervention, but maybe somebody has
Yeah.
another ideas about that. But yeah. Okay. We will.
I mean, there are some studies of electrical stimulation.
Is that physician is giving some substance and telling that next time when you drink alcohol, something bad will happen. So they will change positive expectations related to alcohol consumption to negative.
Sure.
And then when patients really believe that, so then it will work for like maybe for a year, for some people for 6 months. And it has been tried and it has been reviewed also in Norway as a intervention, and they concluded that there is no evidence for it. But after that, from patient side, there was like a lot of objections because some of them really believe that it works for them. So it's mostly like patient preference,
Sure.
and they go for it.
Sure.
So it's
Yeah.
kind of mockery, of course, but we still live with that.
Well, I feel two ways about that. I had a patient that I was treating who told me, if you just hypnotize me, I'll be better. And I explained to him that hypnosis does not have a scientific literature related to alcohol drug problems, and that didn't seem to be something that was useful. So we were trying a number of other things, getting nowhere. And in desperation about the fifth session, I hypnotized him, and bam, he quit drinking, you know? And so in a way, it taught me to use the placebo effect, or what is the person willing to try? And if you get them 6 months of sobriety, that's terrific. I mean, the longer the spans of sobriety, the better the long-term outcome is going to be. At the same time, I've been very committed to controlled clinical trials, so that we know whether this is something that's working by expectancy, or whether there actually is an active ingredient here. So I think both things, you know. I wouldn't try to help people do things that are loony, but the electrical stimulation of the brain is being studied, so kind of low-level, deep stimulation of the brain. I think, well, see if it's helpful. I mean, Bill W., the founder of Alcoholics Anonymous, co-founder, was open to anything that would help alcoholics. He himself experimented with LSD, thinking that this might be something that would be helpful to alcoholics. So I think we need that openness, at the same time, do the science and make sure that it's something that really is working. Yeah.
Just before the next question, I saw you, but just as a comment, there's also, for example, here, using disulfiram.
Oh, yes.
People very much believe in the option where you use the implant instead of the oral intake. The problem nowadays being the implants are very difficult to get because nobody manufactures them anymore. Well, there are a few providers from India or some other areas of that kind, but people believe that this is a much stronger method because you also involve a lot of a little bit of pain and, you know, sewing it under the skin. It's a kind of a procedural thing, so it has some issues. It's a lot about what people believe in.
Yes, it is. And pseudo surgeries with disulfiram have also seemed to produce results. I mean, I think disulfiram is a perfectly good drug. And patients who use it and like it say it's my insurance policy. I'm like, once a day, I can decide I'm not going to drink today, which is what they're told to do in AA also, you know. But the principal problem is people stop taking it. And so implants of medications are being explored with naloxone and, you know, lots of other things as well. But perfectly good medication and inexpensive. And but in the community reinforcement approach, we worked out a daily ritual where the person takes their disulfiram in the morning in orange juice in the presence of their spouse, usually, who lovingly says, "Thank you for doing this. I so much appreciate your commitment to your sobriety." All positive reinforcement. And if either person refuses to participate in the ritual, they call us right away. And we can get them in before the disulfiram wears off, you know. But yeah, I think it's pretty good medication, and it's just underutilized. Yeah.
Ai, seal oli küsimus.
All right, see vist ei tööta praegu, töötab. I work as an addiction nurse, and my question is regarding patients who have borderline personality disorder, because they're the most difficult patients for me. They usually have binge eating issues, cutting. So what's the best way to help them? So what to combine with MI, what type of therapy? Because they have poor emotional regulation issues, and it's very difficult to work with them. So maybe you can give me some ideas. Thank you.
I mean, I think first of Marsha Linehan's work with dialectical behavior therapy, because that's where her heart was, because she herself had the same problem and developed this complex but apparently quite effective therapy for helping people with borderline personality. Now, I think it gets overdiagnosed. She's a borderline is sometimes a synonym for I don't like her, you know. But when there's genuinely borderline personality there's a good evidence base for dialectical behavior therapy. And the spirit of it is very much like motivational interviewing. Interesting study, though. Marsha compared dialectical behavior therapy with a control condition that she called comprehensive validation therapy. What is that? That's doing a lot of affirmation, a lot of commenting on people's strengths and their good efforts in the right direction and so forth. So just lots and lots of positive reinforcement, but none of the rest of the pieces of dialectical behavior therapy. And they finished dead even. I mean, they were equally effective. And to Marsha's credit, she published it, you know? And says it looks like positive reinforcement, like validating or affirming your patient is a really, really important thing when working with borderline patients. You know? I think she still thinks the rest of DBT, which includes teaching emotion regulation and tolerance for discomfort and so forth, is also important. But I don't know anything better than dialectical behavior therapy, and it fits perfectly well with a motivational interviewing way of working with patients. Is that familiar here at all? Dialectical behavior therapy? A little bit, few heads, okay. Yeah.
No nii, kas on veel küsimusi? Jääb lõpus veel aega kommentaarideks, kui kellelgi on midagi väga südamel, aga thank you for this wonderful presentations and
You're
a
very
big
welcome.
applause, I think.